Hi, Dr. Ezon again, here with Virtual Medical Scribes for session 2 of medical scribing. So we're going to go over the note in a little more detail and talk about the different structures. So at the end of the day, remember the reason to have a medical chart is 3 reasons. One is patient care, most importantly, and then there's billing, and there's medical legal documentation. So you have to make sure that your chart note reflects that. In a perfect world, you'd love to have your chart note electronically signed within 2 hours of the encounter, and that we really would like you to do a good job of learning what your physician wants in the note. Listen very carefully, especially with the medical terminology, so that the physician can become more of a publisher than an editor. And as you get better and better, both scholastically as well as with experience, you can reflect what the patient's doing. So medical terminology is sort of a fun thing. I went to a school where I had to take 4 years of Latin, and we used to say this little phrase that Latin is a dead, dead language, dead as it can be. It killed all the Romans, now it's killing me. But in general, a lot of the terms are based off of the Latin. And again, we're very inappropriate when we were in high school, and I'm not sure, Taylor, do you know any Latin? This is semper ubi sub ubi. Again, we're not very appropriate on this, but this means always wear underwear. So it's not a good use, but if you just use Latin, it just sounds better. So we also have to use different words to describe things. Like we've all seen the color red, but in medicine we use the word erythematous. It's 5 syllables versus 1. So we literally have a different crayon box as to what we call things. So as a scribe, you'll hear the physician say these words and understand that you're going to need to learn what the medical term is for different colors. Melon is black, xantho is yellow, erythro red, cyo blue, and chloro is green. And so you'll learn both the Latin roots as well as some of the Greek roots. That's mainly where most of them come from, Greek and Latin roots. So in terms of the medical terminology, interestingly, like Lasix is a drug we use all the time, and that actually comes from something because it lasts 6 hours. Warfarin comes from the name the Wisconsin Alumni Research Foundation. So I like to find out why things are called certain things, and it helps me to remember them, and you might want to use that. Some medications are named after doctors' wives, so I just find that to be a fun way to learn these things. And understand every medication has 2 names. It's generic as well as its branded name. So you'll see a Pixaban is the generic name and Eliquis is the branded name. So as a scribe, that is a bit of a challenge because first off, there's a lot of medicines to learn, and then you have to at least double it by 2 or 3 because each of them has different names to it, both generic and branded. And there is this app that is quite good. There's a free version of it called Hippocrates that is free, and then we professionals will pay for one that's a little more robust. And so this is something you might consider as a scribe to download as an app so that you can look up some of these medicines pretty quickly. HIPAA, again, is about security. It stands for Health Insurance Portability and Accountability Act. It was passed in 1966 to protect patients' health care. So the purpose is to make it easier for the patients to keep their health insurance so that only certain people get the information that's in there. So we really have to be careful about maintaining what's called HIPAA. So it protects the patient health information, and then we have to be very careful what we disclose outside of the secure environment. And PHI, which is personal health information, is financial, personal, and medical information. So it should only you should only give out as much information as they absolutely need, and it's really the theory that you just disclose the minimum that you're allowed to do. And so be very, very careful as a scribe not to divulge patient information that is secure. And then who has to follow HIPAA? Especially the insurance companies have to follow it. The healthcare providers have to follow it, and you're considered part of that team. And then the clearinghouses, which are the billing areas. So there's quite a few different people that may interact with the PHI and have to keep it secure. And then when can a hospital or physician's office disclose the patient's PHI? It's actually once they've been actually given permission to do that. So we really want to be careful with the secure information. And if you breach this notification, that can have dire consequences. So again, security is very, very important. Now I want to switch gears and talk about basically how to do a history and what the physician might be doing so that you can diagnose, you can then document that. And this comes out of the book Bates' Guide to Physical Examination and History Taking, which is a classic that most of the medical students will be using. So the first thing is like, how big is the evaluation? And then the question as a physician and a provider is, how much should I do at each evaluation? So there's different kinds of patients' assessments. When they come in, they're considered a new patient versus an established patient. And then we want to look at what sort of baseline they have, what's their past history, do we have those records, as well as are we going to be doing educational and other things at this visit. So there's a lot that gets done in a visit. So a focus visit is basically usually with established patients, but it can be with a new patient, and it's basically body part specific. So you come in for your knee, that's all we're going to talk about is your knee. And then when you come in, we basically have two kinds of data. We have subjective data, what do you feel about what you have, versus what do we actually objectively discover on our physical exam. So understand that's a big separation. So it's what the patient says and what the history is, which is sort of words and words, and then the other is objectively what they do on the physical exam. And then on a comprehensive one, we'll go through everything. We'll go through their identifying data, male, female, age, but then how reliable are they? If they're inebriated or maybe we're in a car crash or something, they may not be able to give us exact details because they have a concussion or something. And then what's their chief complaint, their present illness, their past, both social and family. And then we go through that checklist or review of systems. So identifying data is age and marital status, occupation, source of the history, and source of the referral. So this sets the tone as to where we're getting all our things from. Reliability has to do is how much how much do they remember? How much are we asking them? And so we sometimes will give a comment on that. The chief complaint is one or more symptoms that cause the patients to come see you, and every attempt should be made to make it in the patient's own words. And if they do that, make sure you put that in quotes. And then present illness. The thought is that this is expounding on the chief complaint, and we'll go through a lot of the different things as to why, in a chronologic manner, why they're here. And then we'll also include their medications, allergies, and then some of their habits, such as alcohol and tobacco use, drugs, and other things like that. In general, this is one of many ways to remember it, but there are 7 attributes to any symptom, like the location of the symptom. You want to put down the quality of the symptom, sharp or dull, the quantity or the severity of it on a scale of 0 to 10. Do you have this pain at rest and then it gets worse with activity? The timing, so it's one of those things where does it happen all the time, or is it episodic? Does it come and go? In what setting? Is it only when they're running or when they're sitting? And then aggravating or relieving factors, like it's better if I put ice on it, it's worse if I have to stand for long periods of time, those sorts of things. And then any associative manifestations, for example, it only happens when I'm in a dusty environment, those sorts of things. So essentially you're a little bit like a detective. You're a little bit trying to look for clues. And in their past history, you can look at their childhood histories, their adult illnesses, especially vaccinations you want to put down, and then their health maintenance practice. Have they had screening things like for a woman, mammograms, pap smears? For guys, have they had rectal exams, prostate exams? For the elderly, have they had colonoscopies? Have they had those sorts of things? So healthcare maintenance practices are what that talks about. And then family history. It's always good to find out about their history. Sometimes they know it, sometimes they don't. But the more of that data you have, that's sort of along the genetics of it. And then personal social, I always like to ask, where you went to high school for my sake, but it just sets the tone as to where have you been, what's your educational level, your family of origin, who's in the household, do you live in a house, do you have other members there, your personal interest, and then your different lifestyle things. And these days, a lot of it is going to be on gender. What gender do you identify with, and what were you biologically born as? Review systems is a systematic way of going through, almost like a checklist on an airplane, where you go through each part of the body and just ask them, do you have anything going on with the nervous system? How's your heart and your blood flow? Do you have any problems with hormones? How's your stomach? So it's a nice way to make sure we don't miss anything. So the second part is we look at evaluating the clinical evidence. And so this gets into a little bit about how confident are we in the information that we have. So you may see this talked about, but it's the validity of the test we do. So in general, what you want to do is to sort of go through and ideally have as many objective data as you can to validate what you're doing. So you may hear us talk about sensitivity and specificity, but in general, sensitivity is how good are you at sort of picking up the disease, and specificity is how confident are we that once you have the diagnosis, that it's a true diagnosis. So you'll see a lot of these things. This is called Bayes' theorem of probability. Just so you know, we physicians will be going through a lot of these sorts of things. And then you'll hear about the prevalence of disease, how often is it there, and then the incidence of it. So a lot of numbers that really don't pertain specifically, but just to have an overview, know that the physician may talk about the specificity and sensitivity of the different tests that he orders. And then in general, we in physicians, we in medicine are trying to promote health. So when you look at the different kinds of tests that we have, we'll look at different ways to decide what should we do in terms of the educational parts of helping a patient and how much evidence is on the research. So this goes along with some of the research things. And you may hear, especially this RCT at the back here, randomized controlled trials. That's the most rigorous amount of information that we will use. So as physicians, we may quote that, especially in the medical decision making. And then you may see the physician also comment on how valid are these different tests and procedures that they've done. And they'll go through different challenges with bias as to the quality of the evidence. And then they'll just be very critical about trying to understand what exactly pertains to that particular patient. So with all of these, we're really trying to figure out the measurement of the treatment that we're doing. And so all these comments are general comments that your physician may relate to you, and these are the ones you put into the chart. So we do look at, does this information actually apply to this patient? So we'll look at also, a big thing on the bottom here is the risk versus benefit ratio. So the physician will go to lengths to explain to the patient the options for maybe a procedure, and they'll talk about the risk-benefit ratios and what's the risk of doing the procedure, what's the risk, what's the benefit of having the procedure done. So these are all things that you want to document. Now we want to switch to the third chapter of Bates and talk about interview and health. So one of the things that we talk about is the different kinds of history. So there's comprehensive histories, which go into great details, versus focus, like why are you here for one particular thing. So the fundamentals of a skilled interview is you want to make sure that the provider and the physician is an active listener. That's why scribing is so good, because we as physicians can focus on the patients and the scribe can document that. We want to give empathetic responses. You'll hear them do guided questions, nonverbal communication in terms of are you focused on the patient, and that's why eye contact is so important for a good encounter and why the medical scribe is so valuable for the healthcare. Active listening, these are some of the things that the physician will do, but most importantly, it has to do with eye contact. So you as a scribe will enable the physician to be able to focus on the patient. It's all about the patient, and yet the physician has work-life balance because you get the documentation done so that he can evaluate it. The physician will do empathetic responses, and You may want to document that. And then after general questions, we may do guided questions. If they complain of a certain thing, we'll take them down that road to try to identify and clarify what exactly they mean. Nonverbal communication is very important for patient interactions, and for a physician to be able to focus on the patient. He allows optimal nonverbal communication by having a scribe so that the patient feel free to give them a good history. And then you may have the physician validate sort of what's happening. So those are the fundamentals of that to start with, and then after that, the physician will do things like reassuring, partnering, and even doing some other empowering the patient to become the best version of themselves. So reassurance is identifying the patient's feelings. Partnering is where we work as a team to become almost like a health coach to help them. And then a lot of times what's helpful is patients frankly don't care how much you know until they know how much you care. And the way to know that is by being able to summarize for the patient what their complaint is, what their medical challenge is, to their satisfaction. That's very empowering, because once you want to first seek to understand before being understood. So once the patient knows, I know what their challenge is, and then they'll be more open to listen to possible advice that we might want to give them. And so then we'll transition them to different parts of the evaluation. And then my goal is to empower the patient, to try to get them to work alongside us to become the best version of them. And then we'll, in general, think that we want to do something where we prepare to care, and that might be something that the physician and provider will do for you as a scribe to get you up to speed as to what we're going to do. And then we actually go through the process, and then we want to keep it in a culturally appropriate manner. So the preparation, a lot of times you want to look at the old records, you want to look at the old chart so that we'll get up to speed. And then you want to make sure the environment in the room is going to be something that is nurturing for the patient. Then during the interview, the provider or physician will greet the patient, treating them with respect, establish the agenda, and then start inviting the patient to tell them the story. And then the sequence is going through all the different, both general and specific questions to elucidate what is the subjective complaints and what is it that they're having. And then the physician will then do specific questions to sort of tease out more of the information, expanding and clarifying the patient's story. And then we'll coming up with a hypothesis of what we think is going on. And then ultimately we will share what our thoughts are, the treatment plan. We will close the interview and then exit. And then sometimes the physician afterwards will do reflections with you to tell you what he's thinking and what else needs to be. Obviously, you want to make sure it's culturally sensitive. And there's 3 dimensions to that. The physician and provider needs to be self-aware of the situation, respectful communication, and then you really want, in these days, a collaborative partnership. So this is a phrase you might hear the physician say quite a bit, because when you hear hoofbeats, you want to think of horses, not zebras. You know, my thoughts are that most of the time, most people have common things. As we say, common things happen commonly. However, now and then you can have a rare thing. Sometimes a hoofbeat behind you could be a zebra that got out of the zoo. That would be very rare, but they do happen. So this is a phrase you might hear us older doctors say, that why we're thinking of a certain thing. So sometimes these phrases are a little confusing to young folks, but for us physicians, we kind of use them a lot. So that's a summary of the first couple of chapters in Bates and how we're going to interview. Our next session will go over some of the other things of well-formulated electronic medical records.